Looking at copper intake, it's an essential nutrient. Rapid growth increases copper demands, especially in infancy. The adult body contains about 100 milligrams of copper, which the biggest concentration places are liver, kidney, heart. The GI tract is where absorption occurs and does require a specific mechanism, the metal binding protein metallothionein. Ceruloplasmin is also a glycoprotein, copper dependent ferroxidase. It oxidizes iron 2 to iron 3, so ferrous to ferric iron in the GI system to optimize iron absorption. And it's going to bind copper. So it can help, it's essentially utilizing copper in this process. This is why there is a relationship between iron intake and copper. Copper is a cofactor also for lots of critical enzymes in metabolism, including superoxide dismutase and cytochrome C oxidase, tyrosinase, monoamino oxidase, and lysolate oxidase. Therefore, copper metabolism can be altered in inflammatory, infectious, and cancer disease states. In an infection, copper is essential for production of IL-2, an interleukin that is created by lymphocytes, our white blood cells. And in cancer, our plasma ceruloplasmin is correlated positively with disease stage. So we see kind of this rise together. So here are some biomarkers that we can consider for copper assessment, some old references, and then some notes for consideration. But the currently accepted biomarker is a serum copper or a serum ceruloplasmin. This is the one that's used most commonly, so this is when we pull from the most. We could consider an erythrocyte copper zinc superoxide dismutase. This is really only in severe states. You could also consider a platelet or lymphocyte cytochrome C oxidase. And some that are up and coming that have potentially been used but not fully accepted is peptidylamide monooxygenase and a copper chaperone for superoxide dismutase. Looking at plasma copper and ceruloplasmin, the two acceptable biomarkers, they both get depressed in deficiency. They plateau when there's an adequate level. They can't really reflect excessive states. Ceruloplasmin has, there's a high percentage of circulating copper bound to ceruloplasmin, and hepatic synthesis will depend on adequate copper supply. The amount of circulating copper is in turn dependent on the amount of ceruloplasma present. There are some problems with measuring this. It's an acute phase reactant, so it's increased with infection, inflammation, and stress. It also can be affected and rise with estrogen. Therefore, you could potentially miss a copper deficiency. Its synthesis can also be suppressed by protein deficiency, and also they are age dependent. Now we're going to come back to chromium.